Okay, I think it's the time we should start the session. Assalamu alaikum and good afternoon from Malaysia. Thank you for joining this webinar 33, which would be mainly looking at how to identify the content of a curriculum, especially in undergraduate medical curriculum. Now, what exactly we want to achieve during this session, that's the learning outcomes. We hope the participants will be able to explain the steps required for developing a new curriculum or reviewing an existing curriculum. That's the one outcome. Discuss the factors influencing the selection of curricular content. Formulate the criteria for selection of curricular content. Discuss the organization of the content in the curriculum and describe the plan of curricular content delivery to the undergraduate medical students. We hope that by the end of this session, we would achieve all these 5 learning outcomes, inshallah. So let us start with the concept and the need of continuous renewal of curriculum. Curriculum development and its continuous renewal are essential foundations for any successful program of learning. Curriculum cannot be static. It needs to be continuously renewed. And there are many reasons for the need of continual renewal of the curriculum. For example, the new content, new teaching methods, new assessment methods. The latest example is COVID-19, which has not only introduced new content, but also the new teaching learning methods and new assessment methods. So with the changing circumstances and the issues and the challenges to medical profession, the curriculum needs to be changed accordingly. The curriculum, can I request everybody to mute yourself, please? Mute yourself, please. Right. Thank you for muting yourself. Right. The curriculum is a live document, and a curriculum tree can explain it in a better way. So like a tree, the curriculum grows and new branches, new leaves appear. The roots becomes deeper and strong, but we need sometimes cutting and trimming to keep it in shape. Some branches need to be cut to let the tree grow taller. The tree grows old. Some of the leaves and branches fall. It dies and it needs to be replaced by new one. So that's exactly what happens with a curriculum, and that's why we call it that curriculum is a live document. There are 6 key elements which contribute to the excellence of curriculum development, namely educational principles and strategic approach. Number 2, content specification and pedagogy, teaching and learning methods and environment, assessment, monitoring and evaluation, academic practices and scholarship, and finally, organizational structure and curriculum management. In this session, we would be concentrating on content specification. the question may arise why we need to define curricular content. And there are a number of important reasons. Defining curricular content helps to ensure that each step in the instruction and assessment process adequately represents the subject matter. Identifying the curricular content creates the boundaries in which the teaching and assessment would take place. The process known as content definition or blueprinting refers to systematic identification of content. Systematic identification of a content from a specified domain. And the purpose is for teaching and creating test items with a high level of validity evidence. For example, identifying the anatomical contents of CNS to be taught to a dental students. So this would be a systematic exercise for identification from the domain of anatomy, and from within the domain of anatomy from CNS, and the purpose would be to find out what should be taught and what should be assessed, and that would provide a high level of validity as an evidence. To identify the content, a backward or a top-down approach is recommended for blueprinting of curricular content. I will explain it in next few slides with some diagrams. Here is the one from BMJ. So we have desired learning outcomes. We write down the students will be able to do whatever it is at the end of let's say a course. And based on those learning outcomes, we identify the content. And then we identify the teaching learning methods. And based on the outcomes, the assessment methods would be identified. Even the content would be identified, the way it is it's taught. And finally, there would be an evaluation. Another diagram to explain it, number one, we have to identify the course goals, right, are the learning outcomes. From that, we drive learning outcomes, and then we choose the content accordingly. So this is a top-down approach, a backward approach. We identify the attributes of a graduate, and then from there, we go down and implement and identify the content, teaching learning methods, assessment methods to achieve those learning outcomes at the end of the course. Here is another diagrammatic explanation. It's an article by Ron Alden. The 5 aspects of a modern curriculum. And on top is learning outcomes. Again, the learning outcomes would identify the content. It will also dictate the teaching learning methods and help also and guide to organize the content and the assessment as well. Right, so that is the concept of top-down approach, means that we have to identify what attributes our graduate should have, and based on that, whether it's related to knowledge, it's related to skill, or it is related to attitude, that has to make the basis for the curricular content, that what should be taught to these medical students or other students. Let's go through quickly through the process of development of curriculum, because it would help us later to understand the concept of identifying the content. The first step in the development of curriculum is the need assessment. What kind of doctors we need. Then based on that, we identify the core competencies. That what are the attributes, are the competencies, are the interestable professional activities our graduates should have. And then based on these attributes or competencies, we identify the learning outcomes. And of course, these learning outcomes would help us how to assess those students. And then we choose the content and then organize the content. And again, the assessment methods would tell us how to teach certain subjects. Then evaluation of the curriculum, and finally, the continuous process of improvement. As I mentioned earlier, that curriculum is a live document and needs to be continuously improved. Here are a few statements about the need assessment, and they are very important statements. Need assessment is a cornerstone of the curriculum development process. Need assessment is cited throughout the medical education literature as a critical stage in the complex process of curriculum design. Identify the required ability of graduates from medical program is considered a primary step in the development of competency-based curriculum. All these statements in the literature with their references emphasize the importance and need to identify the need assessment. An ongoing effort to ensure that the curriculum matches both patients' and learners' needs is paramount to the ultimate success of the curriculum. We know very well that the needs of the students and based on the needs of the patients would keep on changing, and we need to address those changes in our curriculum. How to identify the need assessments? What are the sources we can use to identify what is really needed? It may be health care trends, Ministry of Health records, hospitals inpatient and outpatient records, or GPs patient records, stakeholder analysis, feedback from the students and alumni, and gap analysis. That's very important. It is based on the feedback from the clinicians. And from the feedback of the clinicians, we can determine whether our graduates are meeting the professional requirement and the desired outcomes. Means when students were trained based on certain outcomes, the clinicians with which our graduates are working, they can tell us whether our graduates are meeting our desired learning outcomes. So all these sources, from health records to the stakeholder analysis to the feedback from students and alumni, and from the gap analysis, we can identify the real needs for the development of a curriculum. The second step is determination of core competencies, or EPAs. Based on the need assessment, we need to identify program learning outcomes. For example, learning outcomes of a MBBS program, or learning outcomes of a BDS program, or learning outcomes of pharmacy program. So the need assessment would guide us to identify the learning outcomes. Then we need to translate these program learning outcomes into the professional activities, or interestable professional activities, and these EPAs will help in finalizing the curricular content. So this is an important step that for us to identify the curricular content, that based on the need assessment, we identify the program learning outcomes. And from the program learning outcomes, we identify the core competencies, or EPAs, and these EPAs will help in finalizing the curricular content. Here is a definition of EPA, what we mean by EPA, and this is really an excellent definition. So EPAs are core units of professional practice, some activities, some actions, some procedures, core units of professional practice that can be fully entrusted to a trainee as soon as he or she has demonstrated the necessary competence to execute the activity unsupervised. In other words, EPAs are core units of professional practice, which are activities, are actions, which we expect our graduates to perform independently, unsupervised on day one of graduation. In other words, as soon as the graduates enter for their internship or house officer, what are the attributes, what are the skills, what are the competencies those graduates must have before they start their internship or house job. And this is a good definition of entrustable professional activities. That means that we can entrust the trainee that they will be able to perform these certain actions unsupervised, because we have trained them accordingly. The Association of American Medical Colleges, they proposed 13 EPAs that medical graduates should be able to do or perform with limited supervision when starting residency. So AAMC has identified, and this is the requirement for those who are going to start their residency. The similar practice has been shown in the Canadian medical schools, that they have also identified certain number of EPAs for their graduates. The Medical Council of Ireland has proposed EPAs for the intern year, and in Switzerland, the Joint Commission of the Swiss Medical Schools launched a proposal to incorporate EPAs in all undergraduate medical programs. So these examples tell us that all the prestigious institutions, they have adopted this practice of identifying the EPAs, and then based on those EPAs, they construct their curriculum, they identify their content, and train the students and certify the students that they would be able to perform these actions at the time of graduation. These are some of the references and the points I was just mentioned. You can search for that, and if you are interested, you can read more about them. At University Medical Center, Utrecht, the Netherlands, and from 2016, they train the students to be trusted with indirect supervision before graduation in 5 broad EPAs. So here are the 5 broad EPAs identified by the University Medical Center in Netherlands. Number 1, the clinical consultation. Number 2, the general medical procedures. Number 3, informing, advising, and guiding patients and families. Communicating and collaborating with colleagues and extraordinary patient care. I will explain a little bit more about each of this EPA in the next slide. Each of these EPAs integrates smaller EPAs, means they have smaller learning outcomes, which would ultimately enable the candidate to perform these such actions. And these EPAs, the graduates must be signed off, means that in the medical school, the teachers must sign off, must confirm that students have achieved these EPAs before they go for their internship. Now, here are those 5 broad EPAs which have been adopted by the medical schools in Netherlands. Number 1 is the clinical consultation, and it means history taking, physical examination, measuring vital signs, creating differential diagnosis, ordering and interpreting diagnostic tests, and designing a management plan. And the limitation is that they have to do it on hemodynamically stable patients. So this is 1 out of the 5 EPAs. The second EPA, for example, general medical procedures, and they have identified 23 medical procedures, including the necessary communication with patients as a requirement, as an EPA for the graduates to perform independently. Similarly, there are informing, advising, and guiding patients and families, which mainly involves the general guidance of patients, including discussing diagnostic options, etc. Then communicating and collaborating with colleagues, and finally, basic life support and establish death. So the whole curriculum, including the content, would be based on these 5 EPAs, means everything in the curriculum would contribute to achieve these EPAs before the students graduate. Number 2, determination of EPAs and core competencies. The development of EPA framework would not be possible without a continuous dialogue with clinical teachers. Of course, because these are the exit outcomes. These are the outcomes which a graduate must demonstrate by the time of graduation. So we cannot identify these attributes without consulting with the clinical teachers, especially those who are involved in their training, in their clerkship. Some examples of core competencies are EPAs, and these examples are from dental education. Beginning with the end in mind, that is the top-down approach, the committee identified the qualities and characteristics of the future graduate, and 3 things: an advocate, clinician, and a thinker, but they call it as a ACT framework. The ACT framework created a persona to describe who the emerging dentist would become. So with these 3 EPAs, the whole curriculum would be devised, and someone who serves the community. So the graduate would be someone who serves the communities, provides comprehensive person-centered care, and actively expands and applies their knowledge. Core competencies disseminated by the Royal College of Physicians and Surgeons of Canada, or EPAs, they include medical expert, which is the central role, communicator, collaborator, health advocate, manager, scholar, and professional. The reason I'm emphasizing and spending some time on this concept of EPA and exit outcome is because they would make the real basis of identification of content in a medical curriculum. examples of program learning outcomes. Now, once we have these EPAs, and then based on that, we have these program learning outcomes. And here I'm giving the learning outcomes which have been identified by the Malaysian Qualification Agency. So all these learning outcomes, the medical schools are expected to follow these program learning outcomes, and program here means the MBBS program. The first program learning outcome: apply knowledge of medical sciences in the diagnosis, management, and prevention of common and life-threatening health conditions. That's one learning outcome. 2, demonstrate comprehensive approach in history-taking, physical examination, and investigations in preventive, curative, and rehabilitative management of common and life-threatening health conditions. You would realize that by looking at the EPAs, they are more broad statements, or they are generic statements, or they are general learning outcomes. But when we come to program learning outcome, they become specific. So EPAs are broad statements, and program learning outcomes are the outcomes which would help to achieve those EPAs which have been identified on the national or international level. And that's why you will see the program learning outcomes a bit more specific. Thirdly, display social responsibility towards patient care with respect to individual and community health values. Number 4, demonstrate professional conduct underpinned by ethical values in the management of patients and in dealing with their families, healthcare team members, and the community. The 5th learning outcomes: display teamwork and leadership skills, as well as the ability to communicate effectively with the patients, their families, healthcare team members, and the community. Number 6, apply scientific and critical thinking skills in analyzing and managing patients and related healthcare issues. 7, exhibit lifelong learning skills in information management. And 8th, and the final, is display basic management, networking, and entrepreneurial skills related to healthcare industries. So these learning outcomes, which have been formulated by the Malaysian Medical Council to help the medical schools to develop their curriculum and implement their curriculum, also reflect the national policy on the of the health system in the country. So we have seen examples of EPAs. We have seen the examples of program learning outcomes, and I hope that those examples clear our concept of EPA and the learning outcomes and the difference between them. Now, that background is needed to identify the blueprinting steps for curricular content. So we have gone through a few slides based on the curriculum development, and based on that information and that concept, we will look at the blueprinting steps of curricular content. The first one, as we have just discussed, translate the program learning outcomes into interestable professional activities. Number 2, prepare an exhaustive list of topics based on the EPAs and organize them in the system and miscellaneous group. So whatever the conditions we have identified, I'll give you an example to explain it further based on the program learning outcomes. For example, here we have the first program learning outcome was apply knowledge of medical sciences in the diagnosis, management, and prevention of common and and life-threatening health conditions. So we have to identify the common and life-threatening health conditions in that situation before we identify the topics that should be taught in the medical school. So once we have make an exhaustive list of topics based on the EPAs and organize them under body systems, and those which topics cannot go into the body systems, we can put them under miscellaneous group. Then assess the relative weightage of each topic. This would be a very important step, and we will explain it in detail. So once we have an exhaustive list of topics, of course, we cannot cover everything. So then we have to choose or identify the most relevant topics. And for that, we have to know how to assess the relative weightage of each topic and how to prioritize the topics. Once we have identified or prioritized the topics, then list the content for each topic under subtopic like knowledge, skills, and attitude. Then distribute the content in relation to different levels of training, means year 1, year 2, year 3, year 4, year 5. Then validate the content. So although we have worked on that, we have identified some content, but we need to validate that content. We'll go into the detail how to do that. Then distribute the teaching learning time or duration among body system based on the content. So once we have identified the content, based on the weightage, and they are important and they must be taught. So based on that, we would divide the available time of the course based on the content, and then we would arrange the topics under themes and timetables for integration with spiraling of each component. I'll show you the example of this as well, because we need to integrate the content, and at the same time, we have to make sure that there is spiraling of each component. That means that as the training years go by, students learn more and more about those topics. Okay, now let's go through these 8 steps one by one. The first one, translate the EPAs and the program learning outcomes. So translate the general learning outcomes to specific learning outcomes. And EPAs, as we have already discussed, they are work descriptors and provide discrete and observable tasks that can be measured as a learner develops expertise across the curriculum. As we mentioned earlier, they are core activities which students should be able to do. For example, here, managing a case of severe dehydration or performing a lumbar puncture. So these would be the learning outcomes for students, so that ultimately they can achieve the expected EPAs are untrustable professional activities, means that by the end of the training, when they have graduated, a graduate should be able to manage a case of severe dehydration independently or perform certain procedures independently, these procedures which have been identified in the curriculum. Some example, the PLO we were discussing, identified by the Malaysian Medical Council, that apply knowledge of medical sciences in the diagnosis, management, and prevention of common and life-threatening health conditions. So first step we need is to list common and life-threatening conditions. Once we have got that list, then we have to identify the knowledge, skills, and attitude required for diagnosing, managing, and preventing each of these conditions. So here you can see that how program learning outcome can guide us about the next steps which we need to take to develop a curricular content. Now, how to identify the common and life-threatening medical conditions? There are a number of sources which can be used, like national surveys, Ministry of Health records, hospital inpatient records, or hospital outpatient records. These records would help us to identify the common conditions and life-threatening conditions in that particular community or particular geographical region. Then we have to identify common emergency conditions which may be obtained from Ministry of Health records or accident and emergency department records. Then we have to identify preventable conditions, the conditions which can be preventable, prevented, for example, by vaccination or lifestyle changes. Common causes of morbidity and mortality, for example, 10 causes of mortality from the Ministry of Health records. Rare but potential fatal conditions, feedback from the community, feedback from the alumni, and then international requirements, because we need to prepare students for international medical services like pandemics, etc. So while we are working on the first program learning outcomes, and that program learning outcome requires us to address the common and life-threatening conditions, and this is how we would identify the common and life-threatening conditions. So working on that, we would develop an exhaustive list of the topics which can fulfill the program learning outcome. And for these topics, maybe we take some conditions from the previous list, and then we look at the related topics. We may use the textbooks. We may use the curriculum, the existing curriculum of medical schools. We can look at the WHO literature, Ministry of Health resources. And once we have identified these topics, then we distribute these topics in body systems. For example, in CVS, CNS, medical jurisprudence, and maybe we need to have a miscellaneous group because some topics may not fit in any system. And some topics may be related to personal and professional development and ethics. So far, we have, number one, we have identified the common and life-threatening conditions. Then for each life-threatening and common condition, we have identified the topics, exhaustive list of topics without considering their importance at this stage. And then we divide these topics into different body systems. And those different body systems can also include medical jurisprudence and also the personal and professional development and ethics. So in this way, we organize these topics, the exhaustive list of topics which we have identified. Now, next would be a very important step, the weightage for each topic. Now, we have an exhaustive list of topics, and we know that we cannot cover all those areas. So we have to identify the important our most relevant topics. So for this purpose, we have to use two parameters. First is the impact based on the morbidity and mortality of the condition. Right? So of course, the severe conditions having high morbidity and high mortality, that would be the impact. So for every condition or every topic from that exhaustive list, we have to look at somebody is okay. Now let me say it again, that all the topics we have identified, the exhaustive list of topic, now we have to judge each topic based on the impact, each condition based on the impact. Impact means morbidity and mortality. And number two is the frequency. Number one, that condition, what is the impact of that condition in general, as relation to morbidity and mortality. And number two, how frequent is that condition. So these are the two parameters which we would use to prioritize the topics and to calculate the weightage of each topic. Now, basically, this is a concept which is already being used for assessment. This mechanism and this criteria is used to assess or to identify the important questions which need to be asked in the examination. And this is a table from the University of Calgary. And just to explain to you, but this table relates to assessment rather than the identification of content, but I'm using this to explain that how a concept from assessment can be applied to the content. Now here, this is the blueprint for undergraduate renal course, University of Calgary. And just let's say here are the presentations or topics. So we just take one example here. For example, hypernatremia. The impact is 2, frequency is 1, and when we multiply impact with the frequency, it comes 2. And so under the renal system, we identify all the topics and we calculate their impact and frequency, and then impact times frequency, and then a total. And then based on that, we calculate the weight of that topic or weightage of that topic, which would be total of impact times frequency divided by the individual. So for example, here total is 80, right? Here total is 80, but for hypernatremia is 2. So 2 divided by 80 would give the weightage, and this would be converted into number of items to be included in the examination. So if we use this concept in calculating the weightage of the concept of the content, let's look at this. Now, impact, as I mentioned earlier, is based on the morbidity and mortality. So there are 3 categories. The impact, if it is a non-urgent condition and that cannot be prevented by any means like vaccination or life changes, etc. So impact is 1. But if the condition is serious but not immediately life-threatening, the weightage would be 2. if it is a life-threatening emergency and are a high potential for prevention impact, the weightage is 3. Here I have given the example. For example, meningococcal meningitis is a life-threatening emergency, but it is preventable as well by vaccination. So the weightage for meningococcal meningitis would be 3. Whereas malaria, for example, it is a serious condition, but it's not immediately life-threatening. So the weightage would be 2. Club foot, for example, it's non-urgent and there is a little prevention potential, so weightage would be 1. So there are 3 categories with weight 1, 2, and 3. This is the impact. And then we look at the frequency. If a condition is rarely seen, the weightage is 1. If it is commonly seen, the weightage is 2. And if it's very common, the weightage is 3. Examples here, let's say from, from the pediatric inpatient, bronchopneumonia is very common. So the weightage would be 3. Dengue is relatively common. Weightage would be 2. Tuberous sclerosis is rare. The weightage would be 1. So for each condition, which from our exhaustive list, we analyze each condition based on the impact and frequency. And once we have done that, so then we calculate, as I mentioned in the assessment table. Now here is an example. I'm talking about the pediatric posting. And within the posting, of course, we have to cover all the systems. And I'm applying this concept for the time allocation of each system in that pediatric posting. Now, here I'm taking an example of 3-week posting, which is 150 hours. And I'm putting different systems in the first column. Let's say respiratory. The impact of respiratory conditions is very high. They have a high morbidity and mortality. Frequency is also very common. So impact times frequency would be 9. Similarly, gastroenterology, nephrology, cardiology, and all that, and based on the impact and the frequency, we calculate the multiply impact by frequency, and we add it up, and it comes up to 40. Now, to calculate the weightage of that system here, we would divide the 9, which is for individual system, by 40, and that would give us this figure. And this would be the weightage. And then based on this weightage, we can allocate the time, which is, let's say, total of 150 hours, how much time we can allocate to this system in our posting, and that would be, let's say, 33 hours. This is based on identifying the time distribution among different systems in a single posting. I'll go more into the content now. Now, we have, let's say, identified the time which we need to give to respiratory system. Now we go into the details of respiratory system. Here are the conditions which we see under respiratory system. And then for each condition, we have the impact, we have the frequency, and then we calculate the weightage. And based on the weightage, we can calculate the number of sessions or number of hours. Here, bronchiolitis, it's has a high impact. 3 is very frequent. 3 high impact times frequency is 9, and based on that, we calculate the let's say total is 55. So 9 over 55 gives 0.163 is the weightage, and this based on the time available is 5.7, which we round up to 6. So this means that we have We have 6 sessions on bronchiolitis, but this does not tell whether they are theoretical sessions or clinical sessions or bedside teaching or laboratory. So we have to distribute further. But in this way, we identify the importance and weightage of the content. So bronchiolitis, bronchopneumonia are very common, whereas foreign body inhalation is less common. Asthma is more common. So in this way, for each topic, we can calculate the weightage, and based on their weightage, we would include in our curriculum and in our content. Now, this is just to show you that how to list all those things on one page, but of course, I will explain one by one later. And here is the for each condition which we have identified based on this calculation of weightage are prioritized, then we have to identify the knowledge. And this knowledge can be clinical, paraclinical, and basic sciences. Also, we have to identify the skills as well as attitude. Now, on this page is just one for here, as we mentioned, given for the example of acute myocardial infarction. So when we want to go into the detail of this, so we have identified the myocardial infarction, and then the knowledge and the skills and the attitude. Among knowledge about myocardial infarction, we will have clinical sciences, we have paraclinical sciences, and we have basic sciences. And in clinical sciences, the further subtopics like introduction, including types of acute myocardial infarction, differential diagnosis, and the making a diagnosis of AMI, management, etc., and prevention. Then in the paraclinical pathology and histopathology and pathophysiology, basic sciences, anatomy of the heart and its blood vessels, functions of the heart and the cardiac cycle, ventilation and perfusion, cholesterol, lipids, metabolism, etc. So in this way, once we have identified a topic based on its weightage, then we go into the further details of what is the knowledge required for that condition, to manage that condition, what are the skills required to manage that condition, and what are the attitudes required to manage that condition. Going further into detail of this and explain it further. So we are talking about the myocardial infarction here, and then the knowledge, clinical sciences, paraclinical sciences, basic sciences, skills, knowledge, technique, procedure, interpretation, and attitude, empathy, and communication. The topic, as I mentioned earlier, we have clinical sciences, then we have subtopics, and then we list down those subtopics. Then we have the paraclinical sciences, and we list down the topics under the pathophysiology, pathology, and histopathology. Then is the basic sciences of anatomy, physiology, and biochemistry. So we would identify the whole list. And then regarding the skills for this condition, ECG, stress test, and echocardiography, and attitude for this condition, empathy, communication with the patient and the family, communication with other health care providers, health education, counseling, lifelong learning, ethical and evidence-based practice. So this example explains that what is the process we go through. We identified the learning outcomes. From learning outcomes, we identify the condition, the list of topics. From the list of topics, we prioritize this list of topics based on their impact and the frequency. And then once we have identified these topics, then we, under that topic, we have subtopics which are related to knowledge, skills, and attitude. So we make the whole list of that. So that was an example of clinical content. Here is an example of paraclinical and basic sciences. Again, because we have this top-down approach, so the topics would be the ones which we have identified based on our previous research of common and life-threatening conditions. And then we have prioritized and we have now specific topics, and we have identified their clinical knowledge, skills, and attitude required. Similarly, now the same guideline would be used to identify the topics in the paraclinical and basic medical sciences. For example, we were talking about acute myocardial infarction. So we have to identify the topics in pathology in relation to myocardial infarction, pharmacology in relation to acute myocardial infarction, microbiology, parasitology, physiology, anatomy, and biochemistry. So this means that whatever we are going to teach in the basic sciences and our so-called preclinical years would be guided by what the graduates are expected to do at the time of graduation. So in this way, it becomes very focused and it becomes integrated, and we would know the limits, the boundaries of each topic, that what need to be taught and what need to be assessed. So once we have done that, if we are doing a modular curriculum, then each discipline identifies the topics in relation to clinical relevance, and then the proportionate duration and time is calculated accordingly. And if we are using the traditional system, then we would do only for anatomy, physiology, and biochemistry. Whereas in modular curriculum or other like pathology and pharmacology would also be included. So this is how we would organize our clinical content and as well as the preclinical content. Now, here is an example of preclinical, categorizing the content in relation to clinical relevance within a discipline. For example, we are talking about blood supply. Now, blood supply to brain, heart, lungs, and kidney, to GIT and skin, skeletal muscles, fascia, pleura, or peritoneum. We know that the clinical relevance would be very high. Our impact would be very high in terms of brain, heart, lungs, and kidney. Frequency would be very high. So it would be get the maximum time allocated to be taught about the blood supply. Whereas for example, going to fascia, pleura, and peritoneum would be probably much less time as compared to time allocated for teaching the blood supply to brain, heart, lungs, and kidney. And that's how we can identify the content, the weightage, and we can distribute the time available to us for teaching on those topics. And in this process, when we are calculating the weightage, some topics would be eliminated because they would not be relevant. And in this way, we can pick up the most relevant areas which should be taught in the medical school. Now, once we have identified this, then distribute the content in relation to different levels of the training. So of course, we need to then decide which part goes to which year. For each topic, identify the content, both clinical and basic sciences. Further distribute the contents in clinical, paraclinical, and basic sciences, and then allocate the content for different levels of training: year 1, year 2, year 3, year 4, and year 5. So in this way, the identified content can be further divided among different years. So now we have done that. We have identified that content. We have distributed under different systems. We have distributed under different years, but we need to validate this. It cannot be just one person or few persons' job. This needs to be validated, and so that it is accepted by all. And this validation is, there are different methods of doing that. Curriculum content validation can be defined in several ways. First is directly by subject matter experts. Second, from published curricula or examination questions. Third, by observational study that analyzes what learners need to master. And fourth, through a combination of approaches. So it is very important that we validate the content which we have identified. Otherwise, it may not be accepted by other institutions or other academicians. And I'll go through this and give you different examples to explain it further. The process of validation through subject matter experts. There is no firm consensus on the number of subject matter experts required. However, although it would be ideal to have as many experts as available or as possible to get it validation, but we know that there are limitations to that. We have to look at the purpose of this validation as well as the constraints, the availability of subject matter experts, how much cost would be involved and how much time would be involved. So in literature, different authorities have given different numbers ranging from 2 to 20 members in a panel for validation of that content. So for example, our medical school has identified this content. So we request the subject matter experts from other institutions to validate that. The examples here, in this study, the subject matter experts were first oriented to the purpose of the curriculum, means they're based on the program learning outcomes, the nature of information sought, so what they are expected to do, and then a time frame is given to them, and we explain to them that why they were particularly chosen for this purpose, and also what we expect from them. Here, in this example, the subject matter experts were asked to assess each time in the blueprint, each item in the blueprint for appropriateness and accuracy. So each item in the content or in the blueprint, whether it is appropriate, whether it is accurate, it's not redundant, means it's not being repeated by other items. It's being essential, it's not superfluous, and it is clearly stated. So we send this content to subject experts and ask them to assess this content based on these points: appropriateness and accuracy, redundancy, essentiality, and the style. Style means whether wording is clear and there is no ambiguity. Then the same similar situation in another study where subject matters were asked to suggest any additions of whatever has been given, whether they want to add anything or they want to delete anything, and also to give an overall evaluation of the blueprint with attention paid to comprehensiveness and clarity. So we send these the content which we have identified to subject experts in different institutions and ask them to look on this content based on these points. So once we have done that, and we have now validated the content, we have identified the content and validated the content. Now we have to distribute the teaching learning time among body systems based on the content. So we consolidate the content for each system, and then calculate the time based on the content. I have given the example previously, how we calculate, and then distribute the teaching, learning, and assessment time available proportionately and accordingly. And then we prepare the timetable under themes. Here is an example of a timetable prepared under theme. This is preclinical, and this is a module of hemopoietic and lymphoid system module. And this is the week 1, and the theme of the week is anemia. So in this timetable, you would see that all the disciplines, anatomy, physiology, biochemistry, pathology, pharmacology, and the PBL sessions and others, they are all directed towards the theme, which is anemia in this case. And you'll see it's a very comprehensive timetable. It tells you which is the module. It tells you that which discipline is teaching, and for that discipline, what is the number of sessions and where this session is being taken place. So this is a comprehensive timetable giving all the information in one go. So here is the biochemistry session, then is the physiology session, and the pathology here, right? And pharmacology. So all the disciplines, they are contributing to the theme of the week. And in this way, the content which we have sorted it out is taught under an integrated curriculum. So just a few examples of development of a national curriculum. Here is example of National Pediatric Trauma curriculum, which was it's an example from Canada, I think. And the method was that a team of 4 experts developed content for a national pediatric trauma curriculum, and then disseminated it to 11 pediatric trauma sites across Canada. And so that was the asking for expert opinion, subject expert opinion. The objectives contained both knowledge and skill sets related to management of pediatric trauma patients. And a multi-tiered Delphi process was used to develop the final content. And the results was that all the 11 pediatric teaching centers across the country, they participated. And a final list representing consensus of views was developed in 10 domains through the iterative process of the Delphi technique. And these were the areas identified. The domains of the curriculum included introduction to pediatric trauma and epidemiology, initial management, pediatric airways, shock, thoracic injuries, abdominal and pelvic injuries, spinal and neurological injuries, pediatric head injuries, burns, and orthopedic injuries as well. So this is a very good example of validation of content, that how we can validate the content which we have identified. So finally, it is an intense work. There is no recipe for curriculum transformation. The task to completely reimagine a professional degree program requires significant dedication, resources, and vulnerability. In addition, curriculum transformation is not linear. Of course, it's not a straightforward thing. There would be many revisions, the front and back, up and down, things going. But somebody has to take the responsibility, and probably the person who is taking the responsibility should be relieved from other work, so they can work completely on
You
this.
also
This is an example. Remember, we were talking about the dental students and the ACT framework, which was the advocate, clinician, and thinker framework. CODA here is Commission on Dental Accreditation Standards and EPA of Entrustable Professional Activities. So based on this, they identified the content, and the content was knowledge, skills, and attitudes necessary to achieve outcomes. So this is another example for dental students, how the process was carried out. With that, I thank you for your attention, and I will be happy to answer any questions if you have. All right. See. Let me.
सर इस वक्त पाकिस्तान में लाहौर में ड्रिजलिंग हो रही है और ये जो पिक्चर
Just a minute, please. Just a minute.
सर ये लाहौर में इस वक्त इसी तरह ड्रिजलिंग हो रही है और ये जो आपने पिक्चर पेश की है एग्जैक्टली ये सिचुएशन इस वक्त यहाँ पर वेरी ब्यूटीफुल पिक्चर थैंक यू सर
Right. So yes, let's start with Professor Muhammad Aslam, please.
Thank you very much. It is nice to see you and hear from you and from your wisdom after a long, long time. In summary, in a layman's, I could understand the outcome of all this exercise is to answer to this question, who has to do what, when, where, how, and why. Right. If you can define all these 5 or 6 W's, so that means you have done the curriculum. But with due apology, I would say that today's talk covered very nicely the knowledge and skills component of a curriculum, but it was deficient in attitude because attitudes or ethics are determined by the environment of learning and by the role modeling. Thank you.
Right. Thank you very much, Prof, for your comments. Yes, basically, I tried to do whatever was possible in 1 hour time. Of course, nobody can deny the importance of attitude and how it should be inculcated. But as I said, that every topic must have knowledge, skills, and attitude. And we need to work on that. Very well said, sir.
Thank you very much. Thank you, sir.
Professor Rashid, please.
Yes, Professor Sheralam, thank you very much for an excellent talk. Sir, regarding this mathematical calculation, I think we should also use non-mathematical sometimes, like in the basic sciences, the anatomy, the blood circulation, you calculated fascia, pleura, and peritoneum. According to calculation, it was half hour, but it became 0 hour. So 0 or 1, there should be something in between. We can give 5 minutes, we can give 10 minutes, but mathematically it says 0. So I think some common sense may be used to modify it.
No, sir, definitely. That was an example just to demonstrate. But as I said, the subject matter experts are the people who have the final say, right? But this calculation provides the basis. For example, I claim that this topic is very important. Another person may not agree that this is important topic. So by using this kind of calculation, we can put up our point and assess. The whatever calculation I did is actually reflects my poor knowledge in these areas. But point was just to give the concept. And after you have calculated, the validation is compulsory. And whatever flaws are there in calculation, they would be taken care by this validation. Thank you.
Thank you.
Thank you. Right, Dr. Vidya, please.
Hello, sir. Good morning.
Good. Yes, here in Malaysia, I will say good afternoon.
We are, yeah.
Right.
Just one small query. The slide where you showed that hypernatremia, then hyponatremia on the kidney from the University of Calgary, if I'm right.
Right. Yes.
So if you go to that slide, it says in impact and frequency, you will get the weightage.
Right.
Okay. Now you divide that weightage by the total number. That will give you the sir, can I see that slide, please?
Okay. Let me try. Yes, this is the slide.
Yes, that's the slide. Correct.
Right. So, yeah.
So,
So,
this one number of items, how did you get this number, sir? At 1.5, say, for example, for
okay.
hypernatremia.
No, this one is for examination to assess the number of questions from each
Correct.
topic. Right? So hypernatremia, the impact is 2, frequency
Correct.
is 1. So they would multiply impact times frequency, which would be 2.
Correct.
So they would calculate for all the topics, and then they would add up. So total I plus F is 80. Right?
Correct. Correct.
So now for hypernatremia, because for hypernatremia, I plus F is 2. So this 2 would be divided by 80.
Yes.
And that would give the weight.
Correct. Now, number of items 1.5, sir, that I want to know.
So it's now, here we have total number of 60 questions.
Okay. Okay.
So how much from 60 should come to this?
Got it.
This would be calculated based on that.
So into 60 we have to do then.
Right. Yeah, because it all depends that how many questions you are going to include in that assessment.
Correct, sir. Thank you so much, sir. Thanks a lot.
Thank you. Yes.
Sir.
Yeah. Any other? Yes, Dr. Laikuzaman, please.
So I just want to
Thank you
follow
very
up on
much.
one other question. May I interrupt, sir? The 1.5 question, so it should be 1.5?
No,
Or
I mean that you can round up. You can decide whether it becomes 2 or becomes 1. Basically, sir, this is a guide, and it's just a concept, applying a concept. So, but obviously, experts cannot be bound or cannot be limited by these numbers. Your opinion and your expertise still can overrule this this calculation, but this is a guide.
thank you, bro.
Right. Okay.
Yeah.
Professor Gohar Wajid, please. Please unmute yourself. Yes, sir. Thank you for joining.
Very good morning from Cairo. Good to see you, so many bright faces. And thank you so much, sir, for very elaborative, as usual, I would say, presentation, which has clarified many of the basic concepts. And if a presentation does not add a bit of more confusion, then I don't rate it as a high quality.
So that's the criteria, sir. Then next time I'll make the whole confusion.
Yeah, that is very much expected from a presentation. You know, it should add to a bit of confusion as well.
Right.
But this is the confusion that this presentation adds is not a new confusion, I would say.
Right.
This is an old persistent confusion that is being discussed in the academic circles. about the applicability or the application of EPAs, especially in the undergraduate curriculum.
Right.
There is enough literature available that even argue the application of EPAs at the postgraduate level, but I would not talk about the postgraduate level. But at the undergraduate level, I will not get into the merits and demerits of adding EPA.
Sorry,
But
sir,
if you-
somebody is, the others, please can mute yourself. Yes, yes, sir.
So if you allow me to put it this way, instead of getting into the pros and cons of adding EPAs, if you allow me to say, can we develop, and given the resource constraints and the operational dimensions, applications of bringing reforms in the curricula, can we simply develop the curricula at the undergraduate level without EPAs to keep the things simple and more applicable instead of adding more? Like, why can't we go straight from program learning outcomes to specific learning outcomes and nitty-gritties, as you have said, without introducing more confusion at the level of EPAs, which practically, I would tell you, practically it makes the job extremely difficult to apply them.
Sir, I think I don't have any issue with that statement. As long as we have program learning outcomes, and based on program learning outcomes, we are following the process. I did mention that for every program learning outcomes, we have to identify some core competencies, right? Now, you may call it any name, but for every learning outcome, we have to identify the core competencies. And based on the core competencies, we have to identify the content, which would be knowledge, skills, and attitude. I don't think there should be any problem with that. It's not necessary to stick to the word EPAs, but we can call it core competencies.
Perfect.
Yeah, as long as the purpose is being served. So I hope that I hope the confusion continues, because you said that's the criteria for a better presentation, but I have tried to answer that.
Yeah, I totally agree with you that we can simply follow the approach of competency-based or outcome-based curricula and leave the conceptual issues of application of EPAs to a few medical schools who have all the resources to first refine this technology, make it implementable, and then when the rest of the schools see that EPAs can be implemented and there are answers to how to do entrustments at the undergraduate level, especially the basic sciences level, then they can take it forward and do it.
Fully agree with you, sir. Let's call it core competencies.
Absolutely.
Yeah.
Why I'm saying it? Because WHO is promoting competency-based curricula.
All right.
Yeah, and then, nomenclature, when we add EPAs, it just adds on to some of the confusions that we don't have answers to those confusions yet. Thank you so much.
Thank you very much, sir. Okay. Yes, Dr. Al-Nasiri, please. Dr. Al-Nasiri,
thank you very much.
Yes, sir.
Yes, thank you very much, Professor Alam, for this nice presentation. My question is that in your schools, how many EPS, entrustable professional activities, you use, and what are the challenges you face when you try to implement EPS? Thank you very much.
Sir, as I mentioned, the Malaysian Qualification Agency has already identified the program learning outcomes, which I listed in that slide, the 8 program learning outcomes. So in Malaysian medical schools, all Malaysian medical schools, that would be the guideline followed in that. You can find these documents online if you go to the Malaysian Qualification Agency and Malaysian Medical Council. For each this program learning outcome, they have given quite in detail now we want to call it the EPAs. EPAs are core competencies. It would be given there, but as the 8 at the moment we can say the 8 the figure given by Malaysian Medical Council, and we are following that.
So you didn't apply EPS? I just make it. I don't understand. Is there any EPS in Malaysian Medical School or no?
No, we do, sir. We do, sir. We work on that concept. Yes.
And so, what are the challenges? Because this is a new concept, a new idea. It needs a lot of resources, especially in the assessment. You need a lot of formative assessment, good summative assessment to be sure that they are providing evidence for these EPS. So my questions about the challenges with the student, with the staff, with the resources. And thank you very much.
Yes, sir. We are doing the formal the continuous assessment, our formal assessment and summative assessment, and these are embedded in the curriculum, and they are being worked, and we have certain portion of continuous assessment to be added as a summative assessment. So basically, sir, it seems quite a huge work, but once you plan it and it becomes part of your curriculum, and as long as you are focused, you know your limitations, you have the boundaries, then it can be done very nicely, sir.
Assalamualaikum, sir.
Yeah, I hope. Yes, Professor Musarrat Ramzan, please.
Yes, sir. And so you know that I am in Wa Medical College,
right.
the Dean of Academics. And so we have started this blueprinting, I think for a couple, before, you know, maybe like after 2017, we are already working on it. So we have gone for different ways to like bring in this blueprinting into examinations. But sir, you know that you where you are working, there would be a proper, are you at a university?
Yes, yes.
Yes. So if you are at a university, then you are the one who's going to implement it. But some universities are saying that we will design the blueprint according to the categories and then not bringing in the components. We are exactly making the way you have told us today. I go back to LOs, and then we have the subject LOs, program and subject LOs, and according to that, we decide INF factor and calculate the weight of everything. But you know, we are basic sciences, and we were coming across a couple of problems. So there we added, my question to you is mainly this, that can we make a separate blueprint for the practical activity in preclinical and basic subjects?
Madam, that would be under the cover of the major blueprint, because
yes,
when we come to knowledge, skills, and attitude, so it has to fit somewhere there.
Yes, so I would justify, because you know, some of the you exactly know that some parts are mainly cognitive, and they are not included in those columns are left unfilled when we make this a blueprint, because skills are sometimes.
Definitely, madam. Definitely, yes. I mean, it depends upon what is the topic and whether skill and attitude. So the content would be accordingly. So it's not necessary to fill every column.
Yes. So, sir, and then this can also be, because I was waiting that you would also talk about this, that this will determine the hours of teaching of one part of the curriculum in the total program, and then this is applicable in assessment also, because
Madam, definitely. I mean, if you look at the slides, I have sent it earlier, and I'll send the video recording of this session as well. You will see that there is a time and duration calculation based on the content. You are absolutely right there.
Because only then this blueprint becomes the evidence of constructive alignment in the assessment.
Yeah, absolutely true. Absolutely true. Thank you very much, madam. Yes, Dr. Aisha Abdullah.
Assalamu alaikum, sir.
Wa alaikum assalam.
I just wanted to support you a little in the
that's great.
yeah, in the comments that you're getting for including EPAs within the 6 steps approach. It was great to see you incorporate this concept within the 6 steps approach. Why? Because I feel that this the concept of EPA is a very promising one, unless we mess it up like the previous concept that we have had. Because it was given with the purpose to bridge the gap between theoretical constructs like competencies and competence and the real life practice that we have. So each time that we are writing a learning outcome or a core competency, at the back of our mind, we have this criterion that it has to be linked to a real life practice of a clinician.
Absolutely right.
It keeps us on our toes to not include things that do not have a practice-based rationale for it. So it is a very promising concept in that. And the other thing is that it has got an expiry to it.
Right.
So unless we prove that we are worth practicing it after a while, we can go back to a lesser level of competence with regard to an EPA. And with regard to all frameworks, all curricular frameworks need hard work, whatever form it would be. So EPAs would also need a similar hard work. But the good thing about EPAs at this time is that the groundwork is very ripe for its implementation. We have the work-based assessment tools there to support us to base it on real life experience assessments. And the concept of portfolio is also there to compile all these things. So I think we should give EPAs a chance, especially at undergraduate level, where we see a lot of knowledge growing up as curriculomegaly in the knowledge component, and the practice component gets compromised, especially when there are standardized assessments. So with those standardized assessments, the more of the weightage is going to knowledge, and the older challenge of having more of the knowledge and less of the practice can be bridged through this concept.
Madam, I think you are right. Even those who are not using this terminology, somewhere in their mind, back of mind, these things are there, and these concepts guide them for developing the content. So they may or may not say this, but definitely in back of mind, these things are working. Thank you very much. Dr. Tahira Sadiq, please.
Assalamu alaikum, sir. Thank you very much for a very comprehensive talk. So my question is that I would like to know what is the difference between blueprinting and TOS, that is abbreviation of table of specification.
Blueprinting
because TOS, T-O-S, table of specification.
Right.
Either there is a difference or not, because what my understanding is that blueprinting is something we can say assessment map, maybe, and constructed by examination or assessment unit. And table of specification is what you taught us today. like being subject specialist, how I have to, identify the topics which should be included in examination. So that was the first question. Then the second question is,
let me answer
okay,
this first, madam.
okay, sir.
Basically, you can say that blueprinting is a broad area, and topic of specification is component of that.
Okay,
So it's basically TOS is included in blueprinting.
okay. Thank you
Right.
very much, sir.
All right.
So, am I right in conceiving that blueprint is constructed by some examination or assessment unit, and TOS, which is definitely part of blueprinting, is constructed by by the head of department, by the consensus of different subject specialists?
Absolutely right, madam. Absolutely.
Okay.
They let's say for example, the exam unit would give us a blueprint.
Okay.
But the topic of the specification would be done by the subject experts.
Okay, thank you, sir. So my second question is, just like Dr. Aisha Abdullah was mentioning, that we all know that assessment drives learning. So repeatedly, if we are going to, give students the same MCQs, like we talk about tuberculosis, COVID, or dengue, or these are the diseases which are of common prevalence, if I, talk about Pakistan. So don't you think it would be a repetition, and the topics which we are teaching, and obviously they are not considered much important for their practice in future. So isn't it like we shouldn't be including that in curriculum, or what we have to do
No,
with
madam,
those topics?
if you see, our first point was identification of common and life-threatening conditions.
Yes.
If we identify the common and life-threatening conditions in our community, and we base the curriculum and content is based on that information, so we would be doing something very, very relevant.
Yes, definitely, sir.
Yeah, and so we would be really addressing the needs, rather than reading something which is hardly applicable in that society. So I think the blueprinting of curriculum content is very important in that aspect, that it helps us to identify the most relevant areas which should be taught.
Okay, thank you very much, sir. Sir, my next question is, like, what is the role of teaching hours in calculating the number of MCQs or number of auspices we should include?
No, actually, madam, when we calculate for assessment, we would calculate number of items.
Okay.
But when we calculate for content, we calculate in terms of hours.
Okay.
Yeah, so it's different. If we are doing for assessment, then number of items or number of questions, whereas in the content, it would be topics and the time allocation for that.
Okay, thank you very much, sir.
Thank you. Thank you. Professor Zubair Abbasi, please.
Thank you very much, sir. Very nice presentation. I have a question regarding the integration of the dentistry curriculum, clinical sciences, and the basic sciences. We always had a difficulty in organizing, integration between the basic and the clinical sciences. Do you have the same problem? If yes, then how did you solve it? If no, then what could be the reasons for that? Thank you.
Sorry, sir, can you just repeat a little bit, because there was some issue here.
Right. My question was that in Pakistan, we are having a lot of difficulty in integrating the curriculum of the clinical sciences with the basic sciences.
Right.
Do you have the same problem? If yes, then how did you solve it? If no, then what could be the reasons for that?
Okay, sir. We definitely had that problem, and we have overcome in it to a great extent. And in fact, I wrote an editorial on that in this Journal of Pakistan. There was the College of Physicians and Surgeons. So basically, I have published on that as well, the resistance to change, and unfortunately, there are a lot of misunderstandings between the senior academic staff and the medical educationists. And if you can email me your address, I'll send you that article, and that would definitely answer your question how to go about it. It's a very, very important aspect, and you will get some practical tips on how to handle that.
Thank you very much, sir. I will send you the address.
All right. Thank you.
Thank you.
Yes, Dr. Laiko Zaman, please.
Assalamu alaikum, sir.
Walaikum salam.
Thank you very much. Again, like always, a wonderful presentation, and I'm sure everyone agrees to that. I have one comment to make and a question. The comment is about EPAs. I think we are a little too taken by the idea of EPA, and today's presentation was far less about EPAs and it was far more about how to blueprint the content. So somehow we went a little too far into discussing the EPAs. That's what I think. That is proper. My question is about the calculation. When we are going to multiply impact with frequency for preclinical sciences,
right?
I missed some point in time. I missed how do you quantify the frequency part of it?
Right, sir. If you there is one slide that is about the blood supply.
Yes, it is.
Yeah, if you look at that slide, I think that would give you answer to your question. For example, there was if we want to teach, let's say, the blood supply, so the maximum, let's say, would be to, for example, brain or to kidney or to the heart, as compared to, let's say, talking about fascia.
Okay.
So I think if you look at that slide, it would probably help you to understand that how it can be done. But having said that, I would say it again that this calculation is a guide. Right? So your experience and your expertise can overrule this to some extent, but this can be used as a basis for calculation.
Sir, I did see the slide, and I do agree with what you are saying. My issue was, let's say, how do I give the value of 3 or 2 or 1, any value, and it can be different for different areas of the body, of course. Is it based on my understanding of how significant the understanding of that topic is, or is it about how frequently we come across that content area in our clinical activities?
Sir, it's both. Here, how important that is would be the impact. For example, we are talking about myocardial infarction. So blood supply to the heart is, of course, very, very important. So impact would be 3. And then we are seeing so many cases of myocardial infarction.
All right.
So frequency would be 3 as well.
Okay, so the impact is
basically, sir, what I'm saying here is that you have to relate it to the practicality, the kind of situation with in the community related to the clinical conditions rather than simply theory.
I get it. So that's what I wanted to know. It's at the end of the day, it is going to connect itself to the clinical exposure and the frequency of clinical experience.
Absolutely right, sir. Absolutely. It's because we are talking about common conditions and life-threatening conditions.
I get it. Thank you so very much.
Okay.
Right.
Dr. Vidya, please.
Thank you very much, sir. I just want one help from you. Can you take one session on electives, please?
On electives?
Yes.
yeah, inshallah, we will have in near future. Yes.
Thank you, sir. Thank you.
Okay, thank you very much, everybody, for your participation and giving me an encouragement. And I hope this would be of some help. And I will share the video recording in the same groups. But before we end, I have 2 more slides to share with you. And those are my, let's say, the usual slides. The first is this, sorry. Yeah, this charity drive. So may I propose to each participant to donate $1 or equivalent amount in your local currency to any deserving individual in your neighborhood or any public welfare organization in your community after attending every webinar conducted from this platform. So I would request you to please follow this request and contribute. And the second is the announcement. We will have a workshop. On constructing and marking essay type of questions. This would be conducted on 25th of August. And this would be usually is 2.5 to 3 hour session where we have hands-on practice as a part of the workshop. Thank you very much, everybody, and hope to see you again, inshallah.
Thank you, sir.
Thank you very much, sir.
Thank you very much, Igor.
Thanks,
God bless you all. Thank you. Great.
Thank you, sir.
Thank you very much. Maizatul, yeah.
Thank you, sir, for nice talk.
Thank you. Thanks. Okay.
Allah Hafiz.
Allah Hafiz.